Second white coat. Subscribe and like. Let's learn medicine together.
You know, in medicine, sometimes the absolute smallest clue can make the biggest difference. Today, we're going to unravel a classic clinical mystery. It involves a single nerve, a sudden case of double vision, and one tiny, tiny sign that separates a manageable problem from a full-blown neurological emergency. So picture this. A patient walks in. One eyelid is droopy, their eye is kind of stuck pointing down into the side, and they're seeing double all of a sudden. You're thinking, okay, classic third cranial nerve palsy. The diagnosis seems pretty straightforward, but not so fast. There's a catch. Because when you take a look, you shine a light in their eyes and you notice something really weird. The pupil on that same side, which is controlled by the very same nerve, is totally normal. It's the same size as the other one. It reacts to light just like it should. So what gives? How can one part of the nerve just fail while another part seems to be working perfectly fine? Well, that's the pupil paradox. All right, to really get to the bottom of this, let's walk through a patient case that brings this exact puzzle to life. Okay, so our patient is a 58-year-old man, and his history is important. He has poorly controlled diabetes. He shows up with all the classic symptoms we just talked about: sudden double vision, a droopy right eyelid, and his right eye is pointing down and out. But here's the kicker. You check his pupils, and they're perfect. And that single finding right there is the key that unlocks this entire case. So what's the diagnosis? It's a pupil-sparing oculomotor nerve palsy. And with his history of diabetes, the #1 suspect is ischemia, which just means the nerve isn't getting enough blood flow and is starting to get damaged. It's a classic diabetic mononeuropathy. But how in the world does diabetes, which is a blood sugar problem, cause this really specific type of nerve damage? Well, it all comes down to the tiny, tiny blood vessels that are supposed to be feeding the nerve itself. And that brings us right back to the central question, doesn't it? If a lack of blood flow is damaging the whole nerve, why is the pupil spared? What is it about the part of the nerve that controls the pupil that lets it escape all the damage?
The answer, and it's actually really beautiful, is all in the nerve's anatomy. It's a story about two different kinds of fibers, all bundled together in a very specific way.
Okay, think of the third cranial nerve like a biological cable. Deep inside, at its very core, are the somatic fibers. These guys are the workhorses. They control the big muscle movements, like lifting your eyelid and moving your eyeball around. But wrapped around the outside, on the very surface of the nerve, are these more delicate parasympathetic fibers. And their only job? To make the pupil constrict. This inside versus outside setup is the whole key to solving the paradox. So in a patient with diabetes, that chronic high blood sugar damages those teeny tiny blood vessels feeding the nerve. This can actually cause a mini stroke, or what we call an infarction, right in the center of the nerve. It's an inside job. It knocks out those core somatic fibers, which causes the droopy eyelid and the down and out eye. But because the damage is all central, it completely misses the parasympathetic fibers that are just chilling on the outside. The pupil is spared because its fibers are on the periphery, safe from that ischemic hit in the middle. So here it is, your big takeaway, the one-liner to remember for your exams and for the clinic. Diabetic third nerve palsy is pupil-sparing because the ischemia, the lack of blood flow, hits the central somatic fibers first. It's a simple rule, all based on that really elegant anatomy. Now, we have to flip the coin over, because if a normal pupil is reassuring, an abnormal pupil is a blaring alarm bell. We have to talk about the dangerous mimic. The diagnosis you absolutely, positively cannot afford to miss is nerve compression. And the scariest cause of this is often a growing aneurysm, especially from the posterior communicating artery that's physically pressing on that third nerve. And this comparison just lays it all out perfectly. Diabetic ischemia is an inside-out job, but an aneurysm, that compresses the nerve from the outside in. And what's on the outside? Exactly. The pupil-controlling parasympathetic fibers. This means the compression hits those pupil fibers first, often leading to a dilated, blown pupil before the other eye movement problems even have a chance to start.
This table really sums it all up. Ischemia is an inside-out process, so the pupil is spared. Compression is an outside-in process, so the pupil gets involved early. And that distinction, it changes everything. With an ischemic palsy, you manage the underlying diabetes. But a compressive palsy? That is a true neurological emergency. That means you need urgent brain imaging right now to look for a potential aneurysm.
Okay, so let's boil all this down into a super practical checklist. Whether you're taking a test or you're seeing a real patient, this is your game plan. It's a pretty straightforward 4-step process. First, you spot the signs of a third nerve palsy, that droopy eyelid and the down and out eye. Step 2, and this is the most critical part, check the pupil. This is the fork in the road. Step 3, if that pupil is involved, if it's big and doesn't react, you have to think compression, and you get imaging immediately. But step 4, if the pupil is spared and your patient has risk factors like diabetes, your number 1 suspect is ischemia. The pupil tells you the whole story. So you see, the state of the pupil isn't just some interesting little finding. It is a powerful diagnostic clue that tells you exactly what to do next. It's a perfect example of how one small, subtle sign can be the key to spotting a life-threatening diagnosis, which kind of makes you wonder, what other subtle neurological signs are out there that we can never, ever afford to ignore? Thanks for joining this explainer.